I thank you so much for your attention and your time, and I now welcome Dr. Gracia back to the stage to lead us through the rest of our amazing program this afternoon.
Thank you, Takesha, for that great overview. It is wonderful to see all of the important work that's been done and many of our partners who are here who are engaged in this process. So we are ready now to dive into our conversations, the first of our two panels, which we are calling The Path Forward, for our nation's health and health security. And we really have a fantastic panel here for you. Joining me here on stage is the 21st Secretary of Health and Human Services, Kathleen Sebelius. Secretary Sebelius has been engaged in health policy for decades in the public and private sectors. She served in President Obama's cabinet and as HHS Secretary and was elected statewide 4 times as governor and insurance commissioner in Kansas. Currently, Secretary Sebelius is the CEO of Sebelius Resources, LLC. She serves on several corporate boards and continues engaging in policy work with KFF and co-leads the health strategy group of the Aspen Institute. Welcome, Secretary Sebelius. It's so wonderful to have you here with us.
Thank you.
Thank you. And joining us virtually, yes, technology working for us today. Joining us virtually is the 20th Secretary of Health and Human Services, Michael Leavitt. Secretary Leavitt was elected as governor of Utah for 3 terms and served in 2 roles in the cabinet of President George W. Bush, first as administrator of the United States Environmental Protection Agency, and then as the Secretary of Health and Human Services. After leaving public service, Secretary Leavitt founded Leavitt Partners and has focused on the advancement of value-based healthcare. And he's active as well in corporate governance and currently serves as the chairman of Intermountain Health. Welcome, Secretary Leavitt. Honored to have you joining us as well today.
Thank you. And, good afternoon to all of you, and a special hello to my friend Kathleen Sebelius.
Well, this is really a special opportunity because not only are Secretary Sebelius and Secretary Leavitt former HHS secretaries, as you heard in their bios, they're both former governors. And I just actually learned outside the room when I was speaking with Secretary Sebelius that they were governors at the same time. So really have important perspectives on these issues that we're going to be addressing about strengthening public health and prevention at all levels when we think about this federally, globally, as well as at the state and local level. So we're going to jump right into our conversation with these 2 incredible individuals. Secretaries, you know, there are a multitude of public health crises that are happening as we speak. We're still recovering from Hurricane Helene, preparing for Hurricane Milton, measles outbreaks, rising rates of chronic diseases, the mental health and substance use crisis. Let's talk about priorities and priority setting. What do you see as some of the most important opportunities that the next HHS secretary should be prioritizing when they're coming into their term to improve the health of all Americans? And Secretary Sebelius, we'll start with you.
Well, thank you, Nadine. I want to deviate for a minute. Mike, it's great to see you. I'm sorry it's virtual, but it's nice to see you. And I had the great pleasure of working with Nadine at HHS. She was a trusted colleague and ally, so it's also lovely to see your great ongoing work. I'm fully immersed in public health today because yesterday I got my updated COVID shot and my flu vaccine, so I'm sore on both sides. And we had a medical emergency on the plane this morning as I was coming in, and I watched not only the flight attendants, but an amazing young doctor leap into action. And it was an example of why we all, in an emergency, think public health is a really great idea. Unfortunately, we don't do that day in and day out. So I'd start by just saying, I think your blueprint and the priorities in Tifa's analysis are right on target. I will tell you, as a governor, there is no constituency for public health. There may not be as strong a constituency as is needed in Washington, but at the state level, there is no group that shows up on a regular basis and advocates for money in public health. And those of us who serve in office who are interested in that, I mean, you can tuck money in emergency purposes, you can tuck money elsewhere. But it's a real, I think, brings home the fact that the federal government has to lead in public health, has to drive money to the states, has to, in some ways, I'm a believer, even though I'm a states' rights person, in command and control once an emergency hits, particularly across the country, because states just don't have the resources, don't have the expertise. So whether it's data collection or access to materials or a public health message that needs to be clear and effective across the country, I think the federal government in this instance should lead. And I'm struck, Nadine, by, we're up to now watching Milton barrel toward Tampa and surrounding areas. The language and the preparation and the issues around natural disasters could as easily be public health. We know the communities that are going to be most vulnerable don't have access to transportation, don't have access to food, or have spotty communications, same with health. We know that there's a disparate way to respond. We know some people will listen to the information and some won't. I think for the first time we're seeing misinformation about natural disasters being promoted in airwaves and networks. But I think that Congress would be really wise to first look very honestly at what we learned from COVID, what we did right and what we did wrong, because I think that is a recent experience in public health that we should all learn from. And secondly, really look at the natural disasters, because they somehow, if you move it a little bit away from health, I think people may be able to more objectively look at who are the vulnerable communities, how we drive money to them, who responds, how the federal government interacts with state and local areas, what kind of data is collected, what kind of information is used. And it's an all hands on deck moment. Public health, we are at a crisis point, I think, and we would be wise to see it as a natural disaster that's about to hit us.
That's powerful. Public health being at a crisis moment and the analogy to emergency response.
You bet.
Secretary Leavitt, your perspective on this?
I would hope that there could be two messages delivered, not just to the new government, but also to the American people across the board. The first is just a dichotomy. While we have a need for federal funding of public health, we should never forget that the workforce we're talking about, the public health infrastructure we're talking about, are state and local health workers, not federal workers. When both Kathleen and I were Secretary of Health, somewhere between 80,000 and 100,000 people were employed, but very few of them as caregivers and emergency providers. Those are in the state and local governments. And the message there is we can't let the state and local governments off the hook here. That is to say, they have responsibility. This is a fundamental local responsibility. And if we just depend on federal funding, then we're going to be funding it in a spotty way that's targeted on certain things, but lacks the capacity for local governments to respond. So part of this effort is to just remind the state and the local governments, this is your duty. And we can't be diverting monies away from public health just because we think the federal government might step in. The second thing I will point out is just how crucial public health is to the health economics of our country, which is now more than just health economics. It is our national economic policy. We now spend nearly twice the amount per of our GDP on healthcare than any of our economic competitors. And the way we have made historic progress isn't by twisting the knobs on our healthcare system. It's in public health. When I headed the Environmental Protection Agency, I became very aware that it was not just a regulatory agency, it was a public health agency. And that vast portions of the assistance and progress that we've made in longevity, for example, have come from cleaning the air, from cleaning the water, from creating an environment that in fact does support health. So those two messages, the states have a duty, local governments have a duty as well, remembering that that's how progress is made, is through public health.
Secretary Leavitt, if I could continue on that vein that you were speaking about with regards to that investment in public health and at the federal, but also at the state and local level. Here we are sitting in 2024 and we're acknowledging how important public health is, and yet that investment is still not being made. There's still policy debates happening about investing and sustaining that investment in public health. From your vantage point, how do you see this translating into issues that can help the long-term health of the nation, and how do we convince our policymakers to maintain that attention to these issues in terms of prevention and public health, not only in times of crisis, but in the non-emergency times as well?
Well, we had a very good opportunity, and candidly, there was a window of time when I think people were starting to get this during the COVID-19 pandemic. And when you looked around and said, who can help here? And it was public health officials who were employed by counties and cities and states. And there was a dearth of expertise that people were desperate to find. Yes, there were federal people who were deployed, but the reality was the response came from local and state governments. And we need to move at times like that to underscore that message. They're just, even with FEMA, for example, that's a different kind of an emergency. But those who respond in emergencies, like we're going to see from Milton and others, those are state people who are deployed from other states. And we just need to continue to make that point clear, not just in Congress, but in state legislatures. I think former Governor Sebelius will share my frustration that public health just wasn't understood well enough that when they fund Medicaid, they think they're providing assistance to health. What they're not acknowledging is that there is, in fact, a deep, direct, constitutional duty to public health that is clearly the state's obligation.
Secretary, do you want to add to that? Yes.
Well, I think that Mike and Governor Leavitt and I, Secretary, whatever. You've got too many titles. Administrator, too. That's what the EPA head is called. So he's got another one thrown in. There's no disagreement that safety and security, I think, is the primary job of any official in government, local, state, federal, protecting the health and well-being of our population. I'm afraid in some ways, and I don't mean to be contrary about this, but we're almost too nice in public health. We describe things in very kind of abstract terms and, talk about mortality and talk about life existence and what. We had 1 million people die in COVID, 1 million people. And many of those people were the most vulnerable in the population. That's an outrage in this country, I think. We have disasters that hit and infections that spread. The fact that kids are getting measles again is amoral in a country like this. I think we got to get a little outrage going here, because there is something really wrong with the richest nation on earth, which doesn't prioritize the health and well-being of its citizens. And the data is important, the workers are important, but somehow we have to raise the level of conversation. And Governor Leavitt has referred to the health economics of healthcare. I think it's also a national security issue. I remember as governor, one of the more frightening briefings, and you probably had it too, Governor, was from our National Guard and listening to folks at the Defense Department when I was secretary, who talked about the fact that if we ever had to have a draft again, if we were in the process of having to summon the age-appropriate Americans to go into our armed forces, at least a third of them are not qualified by health condition to serve. Now think about that. We do not have a able-bodied younger generation who can step up and be engaged, involved in defending this country. And that, to me, information like that is probably pretty important to put out into the general stream. Public health, I think, too many people think it's somebody else's health. It's a kind of term that doesn't have real meaning. They know what responding to a disaster looks like. They know what, an after a reaction looks like, but a prevention, I don't think is as clear. And again, there's some wonderful strategies in the TIFA blueprint, but I think our language in some ways needs to be a little more, frankly, dramatic, because we're not making this up. This is about people staying alive. We still have, longevity rates that don't match any of the other nations in our economic strata. That's not a good place to be for it. So we've got to start talking honestly about what the health of America really looks like, not around money, not about, which public programs, but are people healthy or not? And when they're not healthy, what are they not able to do? Not only be good workers, but be good parents, be, good citizens, and how then can that become more of a priority?
I saw some head nods, Secretary, in the audience from when you were speaking about how we speak about public health and pointing, for example, to the more than 1 million lives that were lost in the pandemic and how we are better prepared for this, for a future pandemic. From both of your vantage points, you've been in these kind of difficult conversations, working across the aisle to have these conversations with lawmakers at all levels to be able to prioritize these types of issues. What do you see as potential for this next Congress and administration, but in particular for the next Congress, outlining these issues that you just addressed, where we can have some opportunity for bipartisan work to address the very issues you've been talking about of focusing in on public health?
Well, again, I think going to lessons learned, I really do think we need a real unpacking quickly and very candidly about what really worked well with our response to COVID and what did not work so well, and what we knew and what we didn't know. That's important, to be very candid and honest. Did we keep kids out of school too long? Probably. Did we know that at the time? No. Did we, what were the correct decisions looking back that really helped people, and what could have hampered the health going forward? That conversation, I think Congress is well equipped to do and do it fairly quickly. And then implement some of those lessons. I think also looking at the response to natural disasters. What goes well? What I remember, and Secretary Leavitt probably was experienced with this also, every time we had a natural disaster when I was secretary, the first teams sent in were beyond the emergency response people who unfortunately often brought the morgue, the stand-up morgue and hospital with them, were the mental health folks. Because one of the things that was learned very quickly is well beyond whatever physical health issues there were huge mental health issues and trauma, and it not only hit with the disaster, but it lasted a lot longer. So those kinds of lessons, I think, to implement on a day-to-day life in this country. And is there adequate funding? Are there adequate not only programs and dollars, but the workforce issue, I think, is one of the major crises facing us today. How do we get kids to understand this could be the most exciting, impactful work they could ever be involved in? How do we start that conversation at a very young level, have internships, have, kids who are able to be involved? I mean, you watch children thrilled to go into a fire station and, they visit places. I've never heard of a visit to a public health agency or a description about, what is it that these folks do. But I think we've got to make it interesting and exciting and as impactful as it really is.
Yeah, sounds like we've got some takers of wanting to bring kids into these public health agencies. Yeah. Secretary Leavitt, your thoughts on where there may be some opportunities for bipartisan work in the Congress to advance public health.
One specific example would be in the use of data technology among the states and with the federal government. There were, during the pandemic, some glaring examples of the inadequacy of our approach. You had 50 states gathering data in 50 different ways. That's a place where the national government has to step up and begin to establish standards. That's critical because you don't have situational awareness. If you don't have good data, you have no way of responding properly. I think the second thing, and an unfortunate thing, is that we began to see the demonization of public health people, and we need to just stop that and find ways to make clear what heroic individuals and what noble missions they were carrying out. And I think finally we do have an opportunity with the ongoing onset, which they've always been there, emergencies that have come up periodic, whether they're weather related or terrorist related or in some other biological. Every time we have one of those, we need to use them as teaching moments to highlight the contribution that public health makes to our general welfare. And could I just underscore what I heard Kathleen say, and that is we're in competition as a country, not just economic competition, but our fitness as a nation to carry out the routines of a healthy, successful nation. A nation that is not healthy is not going to compete economically, militarily, or in any other way with other countries. And we're now seeing the longevity of Americans drop. That's simply unacceptable and should be startling to every American. Seizing on moments like we will undoubtedly have to teach those lessons is an important mechanism.
You know, both Secretary Sebelius and Leavitt have brought up this issue about readiness in terms of military readiness. And for those of you that aren't as familiar with TIFA's work, that is an area that we often address, in particular around our portfolio on obesity and chronic disease prevention, and where we've found a lot of interest with regards to seeing these rising rates, whether it's in terms of obesity or other chronic diseases, and the concerns really about our military readiness in terms of having a workforce, a service force that's ready to be able to respond. I think you're placing this, public health is really part of that national security infrastructure when we think about this in particular. Secretary, Sebelius, I want to come back to you because there was something that Secretary Leavitt said around data, and you were nodding your head about the quality and comprehensiveness of data. And I know this is something that you're very passionate about from our work together. And it was not only in times of emergencies, although when you were addressing H1N1, that was a challenge because the data systems were not moving at the pace that we needed to really be able to do the type of response that was hoped for. But you also address this in terms of understanding population health more generally, looking at rates of maternal mortality, looking at rates of chronic diseases, understanding other chronic conditions. What's your perspective on where we stand in terms of our data infrastructure, and both from the vantage point when you were secretary, but also as a governor, how strengthening that data infrastructure can help you in terms of decision making? And I'm asking this question in particular because part of the investments that have been made have been around data modernization, but that's also what's at risk, that's what's under threat.
Well, I think, as Mike said, you can't solve a problem unless you can see the problem, and you can't see the problem if you can't count what's going on. And if, again, lesson learned from COVID, not only was the data full of holes, but people were counting different things at different times in different ways. So it was almost impossible to get a clear national picture. And I would agree wholeheartedly when I started by saying there's some areas that the federal government really has to stand up and be involved. I mean, that's one of them, I think, to have a national count. I mean, right now, I think it is still a voluntary issue where a state can choose whether or not to turn in data to CDC. That's terrifying, absolutely terrifying, because then if somebody says, for whatever reason, we don't have the manpower or woman power, we don't have the interest, we're against your politics, whatever, we're just not going to tell you what's going on. You can't, I think, have a response or a public health system that is that spotty in a country like ours where so many people travel. I do think, we watched huge improvements be made in the Medicaid data system when, along with the passage of the Affordable Care Act, they said you really have to update your enrollment features. You have to make it easier. You have to count people in a certain way. You have a certain way to figure out assets. And I use that as an example where a national program can be put in place. But without that, you really don't know what's happening. So if we're making vaccine, how many people are sick? Where is the sickness happening? With H1N1, as you remember, you could watch it. It was moving across the country from region to region. With COVID, we sort of had a simultaneous national outbreak. But you wouldn't even know that if people aren't turning in data. So I think we're failing at the fundamentals. I still think we do not have a national health data system collecting information in a uniform way. And actually, skilled and trained folks to do that, and then reporting real time, not 2 weeks later, 4 weeks later, 6 weeks later, but some kind of real time reporting so that the response can be timely, effective, and very specific.
And I think you're pointing out, a big challenge with it, which in part too is the fact that these agreements have to be made with each of the states, right? That CDC is having to make these agreements in order to have that type of reporting, and then understanding, as we heard in the video, right, the fact that for some of these health departments, they're still faxing data in because we
probably still
not
mailing
having
it.
the resources to be able to sufficiently modernize for the growing number of health threats, and so really needing to be able to assure we can sustain that.
Well, and I don't mean to dwell on this point overly, but Mike, I don't know about Utah, but Kansas has had I would say, a real step back. So we are one of the states where the legislature decided in response to COVID that they would limit the public health authorities in various places, that they would stop collecting various kinds of data, that they would disallow public health officials. I mean, one of the keys of epidemiology is the track and trace. If you cannot get information, you can't track and trace. That they made it so that it's totally voluntary if somebody reports an outbreak. Those kinds of situations are now part of our law. So God knows what's going to happen next that hits in a state like ours. But we are far less well equipped right now in 2024 than we were in 2020.
And I think you'll see in our blueprint, why we focus so much around data infrastructure. We've seen some important advancements, looking, for example, at electronic case reporting with that modernization effort. You've seen less than 200 healthcare facilities utilizing it to now more than 41,000,
right.
With those types of investments. Imagine what we can do if we continue to be able to ensure that there is that automatic exchange between healthcare and public health, and then also
and health records weren't digitalized until starting in 2009. I mean, that's pretty shocking in a country like this, but we're now actually there so we could share information real time.
That's right. You both have pointed out to an understanding that, we're talking about population health broadly. Yes, and I'm gonna turn this first to Secretary Leavitt, talking about population health broadly. But we know that there are certain communities, certain populations that are disproportionately impacted, not only in emergencies, but when we look at a whole host of health issues. Secretary Leavitt, if I can start with you, how do we not just raise the consciousness, but really raise action to understanding that it's vitally important that every community have the same level of protections, that every community has the opportunity to thrive, but yet we're still seeing disparities, whether it's racial and ethnic disparities in rural communities, disparities that exist among populations that have lower incomes. How do we really continue to raise the importance of this such that it's an understanding that it's not taking from one community versus the other, but it's actually promoting the health which strengthens our nation.
Well, innately, public health is about the health of the community, the entire community, and that we all, a rising tide lifts all boats, and the opposite of that is also true. So again, I think that one of the great responsibilities of public health is to educate. I don't think people are innately desirous that part of a community be underserved. I just don't think they realize it is and the impact that it has on them. I'd also like to say, I think that part of this bringing public health to the forefront is to teach about what is public health. There are lots of epidemics today that we are under focused on. Sleep is an epidemic. The lack of sleep is an epidemic, and it's having profound impact on the lives of Americans and consequently the economics of health. Mental health is not always thought of as a community issue. It is very much a community issue that we need to be focused on. All of these things are part of the public health and are best dealt with in a way. Fitness, obesity has been something we've talked about for a long time, but it's hard to legislate that. It has to be motivating a change of behavior in all of us.
Well, I remember when we were looking at responsiveness to outbreaks, one of the things that New York City did in a way that I don't know that other communities, I mean, this was a while ago, but they had actually mapped situational awareness of individuals who needed oxygen on a daily basis, who was dependent on insulin. And the reason that was important is when power went down, they knew, Nadine, you needed oxygen, but you also lived on the 37th floor of a building and you couldn't get down to get that oxygen. That kind of information, now I know that it sounds a little big brother or big sistery that, you know, that kind of health information would be collected. On the other hand, it's an absolute life-saving piece of information to have, where people live who are vulnerable, how to get resources. You look at, in a natural disaster, pre-positioning water, pre-positioning food, getting healthcare workers on the ground early on. If we did that in health areas, you know, where you knew exactly where to go, where people who need transportation, when a crisis hits, they can't get there. Again, we know a lot from COVID. We know who is on the front lines. We know who are the most vulnerable because, frankly, they bore the biggest cost of sickness and death, ultimately. Heat mapping that in terms of being ready the next time would be extraordinarily valuable, I think. You know, where are the first responders? Where are bus drivers and workers who have to be out each and every day? Clearly, we learned a lot about nursing homes. We learned a lot about other areas, but I do think the health equity is both about, you know, race and gender and issues that, you know, chronic illness that make people more vulnerable, but it also is where the resources and assets are and what kind of different resources and assets do one community need versus another. That should be part of our public health data collection and part of our ability to respond. That can only be done at the local level. Clearly, you can't do that from some federal perch on high, but having local, you know, it's sort of the neighbor to neighbor thing. In a neighborhood, a lot of people know that Mr. Smith, 3 doors down, uses crutches and won't be able to get out of his house as the guy next door, but, you know, they could have a buddy system. That information mapped and spread throughout communities, I think, can be life-saving and important. Social drivers on health to look at where are the food deserts, who doesn't have, I mean, I'm thrilled with the public programs beginning to pay for putting an air conditioner in somebody's house so they don't have heat stroke, making sure that there's food in the refrigerator, getting rid of the throw rugs on a floor so MMA doesn't fall for the third time. I mean, those are as important to health and prosperity of individuals as are, massive clinical programs. So moving more in that direction and understanding, who these individuals are that, again, can only come from the local level.
And you're raising, and we're going to turn to audience questions now, but you're raising, Secretary Sebelius in particular, around these non-medical drivers of health. You lifted them up of transportation, housing, and the quality and safety of housing, and understanding how those structural drivers contribute so significantly to the health disparities that we're seeing. That it goes beyond personal behavior to understand, do you even have an opportunity to be healthy? Do you live in a healthy community that has the resources and the conditions to promote health? Let's see if we have any questions from our audience. And we've got Darla, who's going to pass the mic around to our audience members. Yes.
Well, first of all, excellent blueprint. So
and if you wouldn't mind introducing yourself, and that would be wonderful.
John Auerbach from ICF. And again, really applaud the blueprint. To the secretaries, I was thinking of how difficult it is now because Congress does seem to be deadlocked and unable to pass an expanded budget or pass legislation. That may change. We hope it will change in the future. But I also know that there are things that secretaries can do and administrations can do that don't require congressional action. Executive orders or administrative policies. I guess I wonder for both of you, if you were advising the next secretary about the things that could be done even without congressional support that might be in line with the recommendation of TIFA, what do any of those come to mind to you?
Make Mike go first.
Well, I think both Secretary Sebelius and I would acknowledge that one of the great tools that a secretary has is the ability to draw attention to things. Yes, there are regulatory levers that you have, but candidly, they're defined in statute, and they're going to be even more tempered now because of the Chevron decision than they might have in the past. The real opportunities are to pick an area and to begin to use not just bully pulpit, but the workforce, the tools available to begin to teach the kinds of things that we're talking about. I think one of the things that I look back on as having been among the most productive things that I did while I was secretary was in the middle of a crisis that we were anticipating that the H5N1 flu might in fact become a pandemic virus, and we held 53 pandemic summits, bringing the entire public health community and the business community, the education community together to talk about the role of public health. When Medicare Part D was rolled out, and we have an enrollment every year to begin to rally communities around what can be done to assure that people have the services that they need. Those are things that a secretary can do that can have a profound impact by bringing people who do chronic disease management together, by bringing people who are involved in mental health together and begin to teach both ethic and the tools and what is available now and how it can be used. Going to states and saying to the state legislators, look, we're partners, but this is your basic responsibility. I'm here to help you, and here's some money we can give you to help you, but this is a duty those are things that a cabinet member and member of the public health community can do. I think we really do have to become strong advocates to begin to help people understand how important this is to the economic and medical complexion of our entire state, or our entire nation, rather.
I don't disagree with anything that has been said. I do think that one of the efforts that I was involved in that I think was exciting and hopefully meaningful was this notion of health in all agencies. And you'll remember that. they're, an obscure part of the Affordable Care Act in the prevention area talked about the fact that every agency has assets that could lend themselves to making and helping people be healthier. And it shouldn't just be the health department over on the side thinking about this, but everybody should think about it. So it was a all hands on deck. Every agency was charged with coming to the table. HHS was the lead agency, but coming to the table with ideas. And out of that effort came things like smoke-free public housing. Never had happened before. Set-asides when a new road was built for trails, so that when a highway project went in, there was a place that people could bike or walk. All kinds of efforts that people saw, public health advertisements and vaccine promotion on buses that were part of the. So I think, again, it's really important with public health that all the assets of the government, I mean, you and I saw it, Secretary, when there's a specific outbreak that may be coming our way where it's kind of an all hands on deck. But that structure probably lends itself to a everyday, day in and out. Because when the Secretary of Transportation is thinking about what do I have to bring to the table to make people healthier, what is in my portfolio to do this, it was amazing how creative people could be. Everybody had money. Nobody needed a new bill or a new law or a new whatever. It was just charging them, saying this is really part of what you need to be thinking about as you go forward. And it produced some amazing results, and I think some of that is still very much ongoing. So it's both what assets might be in HHS for the new secretary, but what's in all the departments? What are their opportunities to drive healthier opportunities into communities, work with partners, bring people together. We learned very quickly that, while there was a big effort to get some of the chronically homeless individuals into housing projects, folks won't go into housing projects unless they have services and supports, right? They're not going to go to, as they call them, stick houses without people around them. And at the local level, the housing agencies don't have the authority to bring the services to the table, but HHS did. So we would begin to say to people, okay, we're not going to drive this grant down to the local level unless you, at the local level, put together a community collaborative that includes service providers and housing providers and figure out what your joint effort is going to be. Things like that I think create sort of cross-pollination of good ideas could go on a regular basis.
We've got one more question over here. Secretary Leavitt, were you wanting to make a comment here?
I do. I wanted to put a fine point on. I think the questioner asked a very thoughtful question, and I'd like to, though I think both Kathleen and I have responded to it, I want to give a specific idea that if I were secretary, and I won't be, but this will surprise you a bit, coming from a former Republican secretary. I feel so strongly of the need to unify data collection. And it's not going to be a regulation that does it, but regulation could play a role. The next secretary could go through and look for ways to condition federal money on state cooperation in developing common data standards for collection. And then they would need to bring the group together and collaboratively work those standards out. You just can't mandate them. You've got to get people together and allow them to come up with standards themselves, but put the force of the federal government behind it to say, look, you want money from us. There's something we need from you, and it's cooperation and collaboration to develop something that's going to be good for all of us. But as it is, we've got all these different standards being used to collect data. The forms don't match up, the data doesn't match up, and that's going to take a combination of a little bit of incentive, positive or negative, and a lot of collaboration And that problem could be solved in the next 4 years.
Thank you, Secretary Leavitt. Yes, Dr. Kane.
Virginia Kane, President of the National Medical Association, and just want to commend both of our governors. Governor Sebelius, you gave Indiana University, I'm a founding member of the Indiana Health Information Exchange, and you gave us a discretionary $20 million to get our information exchange started, so I just wanted to commend you for that. Sorry, Leavitt, that you didn't get your chance with us. Okay.
I actually formed the help.
But when I look at the recommendations from Trust of America, when we're looking at the data, and you had suggested increasing funding for the social determinants of health at $150 million. The United States is the richest, #1 in the country for economy. We've got a $29 trillion budget. $150 million for social determinants, adding that to our data sets where we can map our assets and our resources, because our poverty with our populations, especially for the Black communities, Latino communities, it's at least almost 25, 26%. That seems grossly low. I'd like to have your understanding and recommendations how we can combine that. And I have a great example how you could fund, Trust for America, how you could fund all of our large local health departments all at one time for data modernization. But go.
Well, I can start first by saying, traditionally, public health is funded, as you know, more in disease-specific categorical funding, and this kind of cross-cutting funding for public health, whether it's infrastructure, but also to address social determinants of health. I mean, Secretary Sebelius was just making the case of how there is health in all policies. There's still debate about that by some in decision-making positions that public health should be in those spaces. And so being able to actually provide the infrastructure for public health to do this work and not say it's unfunded for you to now engage with every single sector and not have the workforce and capacity to do that. We've seen actually even from these initial investments to support a social determinants of health program within CDC, having these accelerate grants, that these things can show the return on investment. We need to continue to build on this over time. And yes, there's urgency to it. I mean, when we're looking at this, we're in the midst of these health crises. There's urgency. And it's not public health alone. I think that's also an important message, is to say it's not the public health system alone that will solve these issues, but it's truly working with multi-sector partners to be able to address these issues. But we also have to recognize that there is a role for public health in these issues. And I think that ties to what I would end with Secretaries Leavitt and Sebelius on, is there is a concern that there are proposals to actually restructure or limit what public health agencies can do. And from your vantage point as former secretaries of HHS, how does that potentially put the public's health at risk? And how do we convey that it's critically important that we have the mission of public health and the structure of these agencies to be able to do the important work of promoting and protecting health?
So I'm a believer you can't do that out of the public health sector, that you need a broad array of partners. As I said, to have a general, colonel, whatever, talk about the security side of health, to have police officers describe community security based on mental health issues, to have teachers and parents come at this. This has to be a lot of voices and a lot of understanding that this is not like a sector that can sit over here in a silo. It is all of us every day, how we live our lives, how well we're able to participate in the society. And I think those kind of community partnerships, again, the blueprint has a lot of information about strengthening partnerships, but I think having just public health officials, it always sounds too too many people like, oh, it's just your job, it's your turf, you're just wanting more money to do whatever it is you do. We don't know what you do anyway, and we don't really care. We're going to look over here. It has to be a community outcry. And I think then we have to take a step before that, which is do the kind of education that Mike has talked about. I really don't think most Americans have any sense of how precarious our public health situation is, how jeopardized we are as a country economically and in terms of security, how we compare to nations across the globe, how, you know, we have mothers dying giving birth in the United States of America. Outrageous, totally outrageous. So some of this, I think we have to begin to build partnerships, outrage, impetus on the ground, but by giving people real information about what actually is happening.
Secretary Leavitt, anything you want to add?
I'll simply add that we often think of the best response as being more budget, a different regulation or a new statute. There are times when all of those are critical, but what public health, at the heart of public health, has to be extraordinary collaboration and the use of being able to bring people together to solve problems. The questioner asked about public health, or rather health information exchanges. This is a great example where we had essentially said this data problem isn't just among states, it's among people inside states. And so let's form a place where people can come together and collaborate to have information that can be shared. That was formed under one administration. Kathleen and her administration then funded it. We're now almost 15 years since that time, and we're still working on it as a community. But the public health, the secret sauce for public health advancement is skilled collaboration and good leadership that can bring people together as a convener to solve problems. Yes, we need money. Yes, we need regulation. But at the heart of public health is collaboration among players who can solve problems jointly.
Secretary Leavitt, thank you for that message, because I was going to do a rapid response. Final question or statement from each of you. I think that's an excellent one. Secretary Sebelius, what would you like to say in terms of the path forward as we conclude this panel?
I agree.
In a bipartisan
You bet.
fashion. Excellent. Thank you.